Bob, are you able to, at the top of the hour, let everyone in?
Of course, sure.
Thanks.
We're at 6 minutes.
John, is your phone on silent? So if I text you, it won't.
Yeah.
Okay, great. John, can you do me a favor? Well, actually, both of you. I should. You're not seeing my screen anymore. Is that right?
I see the main screen, and then on the column on the side, I see you.
You don't see my slides.
Yeah. Yeah.
Thank you. Navigating Uncharted Waters, Simulation in the Age of COVID-19.
Weird. I hit pause share and it seems like it didn't pause. Okay,
No, it's up.
never mind.
It says you are viewing Christine Park's screen.
That's really weird. Okay, I will not use that feature then. All right, everybody, break a leg.
Great, we have 3 minutes. Should I let people in?
Hey, do you want to let people in, you guys? You can take yourself off of video until the top of the hour. Okay.
That's good. Break legs.
All right.
And I'm letting them in.
Good morning, everybody. All right, good morning, good afternoon, wherever you are. Thank you so much for joining us today for this exploration and for this discussion. We're going to be talking about in-person standardized patients during the COVID-19 pandemic. Is it an exploitative practice or necessary for education, or perhaps some other answer? My name is Christine Park, and I am the director of the Simulation and Integrative Learning Institute here at the University of Illinois College of Medicine, where I'm also a practicing anesthesiologist. I'm a past president of the Society for Simulation in Healthcare, and during that time was very privileged to lead a global group of simulation leaders from 25 countries around the world to create a unifying code of ethics for healthcare simulationists. My interest in simulation really is leveraging its power for transformational change. And today I'm joined by two other excellent colleagues. John Chenault is an associate professor and clinical librarian at the Kornhauser Health Sciences Library at the University of Louisville. He also serves as an adjunct faculty in the Department of Pan-African Studies in the College of Arts and Sciences at the U of L. His research interests include informational literacy and library instruction, medical history, slavery in medicine, health disparities, and medical education. His work has been published in library science and medical journals. And I'm also joined today by Carrie Bonert. Carrie directs the Standardized Patient Program at the University of Louisville. Ms. Bonert co-authored the Association of Standardized Patient Educators Standards of Best Practice, which you're going to hear referenced a little bit later. First as chair of ASPE's Education Committee, and then as its vice president for operations. This fall, she began coursework for a PhD in applied sociology. Her recent research has focused on the engagement of transgender and gender expansive standardized patients in medical education. So this event is being co-sponsored by the University of Illinois and the University of Louisville. And without further ado, let's dive in. So we're here together today to examine some examples of exploitative practice from history. We're going to reflect on standardized patient history, and we're going to explore how the COVID-19 pandemic really challenges us to reconsider this history. This is a subset of the simulation agreements that we use here at UIC as learners begin their simulation encounters. And I'd like to share with you a few of these and set them as the agreements for our discussion today. We are going to make room and find worth in all voices. Own this with us. Try it on. Let's have unconditional positive regard for one another, practice humility, and surface cultural assumptions. Now let's go to the polls because we'd like to know a little bit about who's with us today. And we have two questions that we'd like you to answer. The first question is, how do you identify? I identify as a, and select all that apply. Simulation, hold on. As a simulation professional or simulationist, a clinician, administrator, academic, or curious human. And question number two, with respect to simulation education, I mostly, and here we want you to select the best answer, participate as a learner, develop or implement simulations, shape practice within the simulation center, or shape practice in a broader organization, institution, company, and so forth. And if you don't find yourself here, please do share it in the chat. All right, so we're going to let this go just for a few more seconds. All right, I'm going to go ahead and end the poll, and you can see the results here. So most people on the call today do identify as a simulation professional or simulationist, but we have a good breadth of people, including lots of curious humans. And then in terms of simulation education, Bob, I cannot see the answers. Here we go. So most people are in the zone of developing or implementing simulations, but we have a fair number of people who shape practices within their center or their organization or company, and a few who do participate as a learner. Thank you so much for that. All right, and with that, I am going to pass the baton to John, who's going to give us the first section here.
My brief presentation asks us to consider if the historical development of U.S. medicine within the context of racial slavery in the 19th century still informs and impacts medical education today. The specific question formulated for this purpose is suggested by a series of incidents that occurred in the antebellum period of the 19th century, when medical education began, and when physicians and medical educators openly exploited vulnerable, enslaved, and impoverished human subjects to learn and teach medicine. So, here's the question that I have formulated for our discussion today. Is Anarcha a standardized patient? Who is Anarcha? What is taking place in this scene, and where did it occur? Anarcha is the woman depicted kneeling on the examination table, and Betsy and Lucy are the two women looking on from behind the curtain. They were among the 11 enslaved women used to make a major breakthrough in gynecological surgery during a 4-year period from 1845 to 1849. Historian Deidre Cooper Owens coined the term medical superbodies to describe enslaved women and the immigrant Irish women who bore the brunt of medical research and education in this formative period that established gynecology as a medical specialty. In some ways, the term is evocative of the contemporary notion of a standardized patient, given the specialized roles the women performed in medical education and training. In the specific case of African-American women, the term medical superbodies also denotes the unique pressure placed on them to be breeders rather than mothers. It also refers to their stereotypical portrayal by medical doctors as impervious to pain, able to work until childbirth, and capable of easy deliveries and resuming their duties immediately thereafter. Racial slavery in the US was hereditary. Legal enslavement for life began with being born to an enslaved mother. Chattel slavery therefore depended entirely on the reproductive health and capability of enslaved African-American women. Consequently, after Congress banned the transatlantic slave trade from Africa in 1808, the only way to increase the numbers of enslaved people in the US was through reproduction. Enslavers therefore had a great monetary interest in the fertility of enslaved women and expected multiple births from them or their value would be diminished. This capitalization of the Black womb meant that enslaved African-American women were among the first in the nation to receive free health care, not for their benefit, but for the benefit of their enslavers. As Deidre Cooper Owens points out, Black lives mattered medically because they made white lives healthier and better. Let me repeat that quote. Black lives mattered medically because they made white lives healthier and better. I will add, they also made them wealthier. In 1845, a young girl of childbearing age would be valued at approximately $400, which, when adjusted for inflation, is equivalent to $13,680 today. During her reproductive years, her enslavers expected her to produce human property to increase their wealth by tens of thousands of dollars. James Marion Sims is known as the father of gynecology. He is the man facing Anarcha in that artist's reproduction. Sims pioneered the development of the medical specialty of modern gynecology, despite his initial reluctance to treat what he referred to as disorders peculiar to women. He stated in his autobiography, "If there was anything I hated, it was investigating the organs of the female pelvis." A native of South Carolina, Sims graduated from the Jefferson Medical College in Philadelphia in 1835. He moved to rural Alabama after graduation to treat the local citizenry and enslaved men and women on various plantations, before moving to Montgomery, Alabama in 1840, a city in which 2/3 of the population were enslaved, and where he became the most successful surgeon in the state. In the 4 years he treated Anarcha and the others, Sims invented the speculum that bears his name and developed the Sims position for rectal exams and treatment. That's his famous speculum, and this is the Sims posture. These innovations not only laid the foundation of modern gynecology, they enabled Sims to build an international reputation as a physician and surgeon. By his own estimate, his successful practice eventually made him the second wealthiest doctor in the United States. This scene is set in the private 11-bed hospital Sims built on his property to treat and experiment on enslaved patients and to learn and teach medicine in the process. Medical schools, clinics, and Negro hospitals sprang up along the main routes of the domestic slave trade as slavery expanded across the South. Note, the map shows 3 types of infirmaries for the enslaved: college, commercial, and small experimental clinic, all of which were designed to function as teaching hospitals. Sims's hospital fits the category of an experimental clinic given its size and purpose. The use of enslaved people for medical education was the established practice in the United States, especially in the antebellum South. The South Carolina Medical College, the leading medical school in the region, was typical in advertising its unique educational resources to attract prospective students. So this excerpt from an 1830 ad placed by the college in the Charleston Newspapers states, "No place in the United States offers as great opportunities for the acquisition of anatomical knowledge, subjects being obtained from among the colored population in sufficient number for every purpose, and proper dissections carried on without offending any individuals in the community." The ad also announced the college had established a surgery for Negroes for the benefit and instruction of its students. It ends by pointing out that the school's sole object was to promote the interests of medical education. The medical use and abuse of enslaved African Americans, Irish immigrants, and other vulnerable populations provided the foundation for modern medical education. Much of this education occurred in the form of instructional theater, the live performance of examinations and surgeries as spectacle, starring medical super bodies drawn from the enslaved and lower classes of US society. Anarcha and the other women endured multiple painful surgeries by Sims to treat vesicovaginal fistulas, an abnormal connection between the bladder and the vagina that allows the continuous involuntary discharge of urine into the vaginal vault. This condition occurs due to complications from prolonged labor or from injuries caused by forceps during delivery. Such injuries also could cause rectovaginal fistulas, a condition that led to fecal incontinence or leakage of feces into the vagina. The constant odor of urine and feces from the fistulas consigned affected women to a miserable and marginalized existence that undermined and destroyed spousal and familial relationships. regardless of social status or skin color, affected women were equally desperate for a cure. Sims leased Anarcha, Betsy, and Lucy for 5 years from their enslavers and purchased 8 other women on which to train. He not only perfected the surgical procedure on them, he also trained them as nurses to assist him and no doubt benefited from their insights. In Anarcha's case, he performed 30 surgeries over a period of 4 years to achieve what he considered a cure for her vesicovaginal and rectovaginal fistulas. Everything we know about Anarcha and the other women comes from his journal articles and the autobiography published after his death in 1883. Sims introduced his surgical procedure in 1852 in the American Journal of the Medical Sciences. Although Sims mentioned their essential roles in his surgeries, none of the enslaved women appeared in any illustrations of it as patients or assistants. Anarcha, Lucy, and Betsy never received the recognition they deserved as the mothers of modern gynecology, despite the fact Sims confessed in his autobiography that when he thought his efforts were futile, it was their persistence, steadfastness, and endurance that convinced him to keep going, and that proved critical to his success. In 1853, Sims moved his practice to New York, where he co-founded the first women's hospital in the United States in 1855 and solidified his reputation as a leading expert in women's health. His work with Anarcha and the other enslaved women enabled his advancement from an 11-bed hospital in his backyard and a storefront office in town to this. In questioning how standardized patients are employed today in medical education in the midst of the COVID-19 pandemic, it may be useful to consider if parallels or precedents exist in the 19th century that have implications for current educational practices as they apply to vulnerable groups such as women, so-called minorities, and the poor. Here are the facts to consider in answering our question. Sims repeated the same procedures on the same patients, thereby standardizing both to facilitate his own training and the education of his students and other physicians. Sims educated and trained his enslaved patients to be surgical nurses to assist him. Sims often performed his surgeries for public view. Sims advanced medical education, clinical practice, and his own career using enslaved women as medical super bodies for that purpose. Did Anarcha and the other enslaved subjects of Sims's experiments ultimately serve as simulations in the sense of performing as surrogates or stand-ins for the white women who were the intended beneficiaries of his training and treatment? Is Anarcha a standardized patient? And with that question lingering in the air, it's time to turn to our next presentation.
Thank you so much, John. There we go. Now I will chat for a moment while I pull up my slides. Should have done that already. My apologies. So I do want to let you know that as a community, I want to let you know that when I introduced John to ASPE, this is what I was hoping for. I was hoping that we would get beyond just a plenary and into further conversation about the implications of the history of medical education and Black bodies, to use John's word, so that we can better understand things like recruitment and retention problems that we have, medical mistrust in the community. These are all important topics for us to talk about. And when I first encountered John's expertise in this area, that's really where I first thought is, oh my gosh, no wonder we have difficulty with recruitment and retention of SPs from minoritized community, because this is the way they've been treated by the medical education community. So, okay, let me just share screen here. Okay. All right. So from here, what we're going to do is we're going to transition into talking about SP methodology. So we're going to fast forward over 100 years to the 1960s and the 1970s, and we're going to talk about where standardized patient methodology started. And for many of you, this is a review, but indulge me, please. So Dr. Howard Barrows was a neurologist, and he first also used a real patient with real medical problems. So he used a patient named Sam to evaluate his residents because, you know, one of the things that we know about simulation is that it's an effective teaching and assessment tool because we can craft one experience that's seen by multiple students, which is very different than when they go into the clinical environment and they may see 7 patients with MS, but those 7 patients may present differently. So this is where Dr. Barrows really figured out, okay, I can send all of my residents to see Sam, this one patient, and then have them present to me or talk to me, and I can really then see what they're picking up and what they're missing because I know this one patient in this one case so well. But what happened was Sam didn't appreciate the way he was treated by one of those residents. And so his response was, oh, don't worry, I fixed him. I moved my Babinski to my left foot and I changed my sensory findings. Boom, genesis of an idea, the germ of an idea here. So Dr. Barrows realizes I can train individuals to simulate physical exam findings. And it goes from here. Then we have Dr. Stillman, who was training mothers at the time, mothers of pediatric patients, to assess residents using an assessment tool. So Dr. Stillman brings us the idea that we can have lay people use an assessment tool. Dr. Barrows realizes we can train physical findings. The two of them work in the same institutions, and we combine those things into what we know as SP methodology today. So let's see, I'm going to have to use this and not my arrow buttons. Okay, so the impact, I apologize for the small size of the font here. I opened a different slide deck than I intended. Is when we go through the literature, we notice that there are effects on standardized patients beginning in 1995 with Crystal Woodward and Gail Gliva-McConvey's publication. We notice that there are physical symptoms of simulation or effects of simulation like exhaustion, the need to feel like they have to pull themselves back into their normal lives after emotionally charged roles. On the positive side, this can feel exhilarating. SPs can become more articulate or report that they become more articulate. They report that they become better self-advocates and that they experience greater open-mindedness as a result of having portrayed someone with a particular diagnosis. In 1999, Nancy McNaughton, along with her colleagues Tiberius and Hodges in Toronto, looks at the effects of she's in this instance, she's only looking at psychologically or emotionally complex roles, emotionally demanding roles. And 89% of the responses reported some sort of negative effect of these simulations. Things like exhaustion, she reports that was both mental and physical. Some physical trauma, psychological irritation, sleeping problems, stiffness, muscle tension, headache, puffy eyes, and blotched skin from crying. The thing that really stands out to me about this is that these effects could last anywhere from a few minutes or hours, like the blotched skin, to a few days. 11% of responses then also noted some positive benefits of participating in emotionally complex scenarios, like having fun performing challenging roles, rising to the occasion, feeling a heightened sensitivity and awareness, or feeling calm. So I believe that this is the genesis of the value of safety that we have now put at the absolute pinnacle of our practice. We talk about physical safety, psychological safety for all simulation participants, including learners, ops specialists, faculty, and standardized patients. So Christine, we'll talk more about that in a moment. In 2004 then, from, I believe this survey was performed in Switzerland, not in the Netherlands. I'm not sure about that. I know that several of these authors are from the Netherlands, though. So they asked about specific stress symptoms. And so it wasn't an open response. This was crafting things from a list of response: exhaustion, being anxious, eating more, back pain, perspiring. They also uncovered some motivations for doing standardized patient work or simulated patient work: feeling useful, the educational aspect. The SPs enjoyed contact with others. They wanted to work for money. They appreciated feeling valued, or that was motivating for them. And also the opportunity to act was motivating for them. 73% of these survey participants reported experiencing the sum of the stress symptoms noted above. What stands out to me is this last part, that the mean was 4 symptoms per SP. So we see that there absolutely are effects, physiological effects of simulation. And this is where we start to talk about the risk and the benefit. And again, why we so highly value safety. So we can talk more about how is it that we work to ensure SP safety. We hope that you'll participate in discussion at the end of this presentation about how we protect our standardized patients. So the same authors then conduct another study a couple years later. And in this one, the SPs report effects. They're mostly minor effects. The effects they describe are exhaustion, dissatisfaction with their own performance, which I find really interesting. So that's that internal motivation. Physical complaints due to the performance. And those included things like postural, holding a postural change might cause back pain. So some folks reported, I think it might be in this slide later, but yeah, headache due to reading without their glasses, because if the character didn't have glasses or didn't wear readers, then the SP may have been performing without glasses. So again, more effects described: continuing to feel or act like the person portrayed, and experiencing real symptoms that interfered with their simulation. So among the physical complaints reported in this study were abdominal pain due to palpation, breast pain due to palpation, headache due to reading without glasses, backache due to uncomfortable positions, worsening of eczema due to performing bad news roles. So we see there that somatization of the emotional stress. So it had physical consequences for at least one SP, and exhaustion. There was a quote in this article that I'd like to highlight just to give voice to a particular SP who noted that after seeing X number of students per day in breast palpation and breast exams, one would simply expect tender and sore breasts after that much palpation. So that brings John's question about superbodies and medical superbodies to me, because our standardized patients are not coming to the medical establishment for healing of their own problems. They are presenting their bodies as learning tools, which, yes, we all know, but then when we relate this to the context, are standardized patients a form of superbodies? That's another question we can discuss later on. So then this is a study that is published ahead of print right now. It's my research team that I work with. You see, I'm down in the list here. There are many more important people than me on this study. But we looked particularly at the experiences of gender minority SPs. We define gender minority as transgender, non-binary, and genderqueer. Those are words that were used by the standardized patients within our study that we then repeated and published. And we did see that during simulation, they experienced microaggressions. Some SPs experienced microaggressions related to their gender identity. These standardized patients were portraying their own gender identity. They also expressed some positive experiences from participating in simulation. So things like altruistic benefits, they felt like they were really paying this forward to the community and helping to build practitioners who would be able to better treat transgender, non-binary, and genderqueer patients. And that was particularly motivating for them. They had a humanized view of medical trainees. So rather than seeing a doctor as sort of a flat persona without humanness, this really brought to life for the standardized patients that medical learners are complete human beings who come into situations with their own fears, loves, passions, biases, etc., but that they are whole individuals, whole people. And it also gave them greater insight into medical education, and that was something they noted as a positive effect of participation in simulation. So to bring this all together, the risks, if we summarize from these articles that I've highlighted, are physical discomfort, emotional discomfort, and these can last minutes to days. The benefits we see are better self-advocacy skills, increased open-mindedness, becoming more articulate, having fun, and gaining greater insight into medical education. Motivations for SPs were altruistic factors, absolutely number one when you look across the articles. Money was on the list, social connection was on the list, and opportunities to practice acting skills. So what stands out to me here is when we think about the COVID environment and we think about these motivating factors, the COVID environment has taken away opportunities for many of us to practice altruistic behaviors. It has taken away from many of us the opportunity to earn money. It has definitely taken away, all of us can think of how it has detracted from our social connection. And for those who are interested in acting, it has taken away the primary platforms for them to practice their craft. So COVID, when I look at this data, I see that direct line. The SP motivations, I'm going to put my own word on this, but there can be a hunger related to these motivations because the experiences that feed those motivations have been taken away. So from here's my reference list. The slides will be posted later on, and so you will be able to go back and view this reference list. You can screenshot it now if you'd like as well, if you want to go back and look at any of these articles. So I'm going to go ahead and stop screen share and pass to Christine. Let's see here. I managed to cover up my controls. There we go.
Okay. So now we're going to come fast forward to today, to 2020. During this global pandemic, and especially as pressures mount to resume in-person simulation, we really need to think about accountability for worker safety, and especially for those who are hourly or on-call gig workers, temp, episodic workers, for them coming into in-person work, especially for situations when physical distancing cannot be maintained. So I want to draw a distinction right away from providing work and supporting our community through telesimulation or remote simulation opportunities versus having them come in for in-person work. This is a screen grab from the COVID-19 training that every single person at UIC had to take with respect to coming back to work in person. So the guideline is, if you can work from home, you should continue to work from home. If you cannot do that and you have to come in, here are the rules that you need to follow. And you see pulled out here, alert your instructor or supervisor if any activities do not allow for at least 6 feet of distance between yourself and another person. So what we're talking about is when we ask SPs to come back in, if we're going to ask them to violate this work safety guideline, what is the reason why? And do we believe that that's important? And is it possible that they may be unduly vulnerable in our ask of them to do these things? It's important here to draw also a distinction between essential from a labor perspective and essential as a value proposition. This word is used a lot. When I use the word essential, I'm talking about it from a labor perspective. So that means that their physical presence is required to maintain societal infrastructure. So I, as a physician, I'm an essential worker. Somebody who is perhaps a plumber may be an essential worker. Essential as a value proposition, we accept that. The people who help with education are integral, they're immensely valuable, but they're not essential from a labor perspective. Our hourly workers, and I'm going to use this as a generic term for the rest of the talk, are vulnerable. They include people who are standardized patients or simulated patients, ops specialists, technical instructors, and other episodic workers. Many of them do not have employer-sponsored insurance here in the United States, or their premiums may be prohibitively high. They are often financially vulnerable or outright poor, and are often vulnerable to inequitable power dynamics. So John at the top of the presentation here talked a little bit about these kinds of dynamics at play. And while I think any one of us would consider any of those practices from 200 years ago to be flagrantly unethical today, our question is there even a little bit of a remnant of that in some of our decisions? Carrie, who was a lead author on this, the Association of Standardized Patient Educators Standards of Best Practice, in their first domain, talk about the safe work environment. And that includes anticipating and recognizing occupational hazards and ensuring both psychological and physical safety for everybody, not just the patients, not just the learners, but also the simulation workers. The Code of Ethics talks about multiple areas that apply here, talking about eliminating unnecessary harm, maximizing safety, and minimizing physical and psychological risk. And importantly, maintaining vigilance about potential unintended consequences of the simulation activity. And when this code was written, by no means could the author group have predicted that we would be thinking about it in the way that we are today. So this is a pyramid that many of you may be familiar with. It's the NIOSH safety pyramid, talking about a hierarchy of controls. When we think about PPE and wiping down surfaces and talking about that as having achieved safety, this really puts it into context. If you can see that PPE is the last and least effective way of protecting people from an occupational hazard, the last and least effective. So in-person work comes very far down in this pyramid on the hierarchy of controls, whereas remote work, supporting remote work, is higher on that pyramid. I wanted to touch on asking people about their feelings of comfort. We have been hearing a lot of places saying, well, we asked our SPs and they said that they were comfortable. We do acknowledge that that's reassuring to hear. At the same time, we should also realize that most people are not trained safety or hazard experts. Their answer may be influenced by financial pressure, power imbalances, and most importantly, feeling safe is not the same as being safe. It would be like asking one of us, any one of us, after a fire in a building, do you feel safe to go back in, and using that as a metric? Of course, we would never want to do that. So we wanted to survey our hourly workers and to understand their COVID-19 experience. And we specifically didn't want to ask them, do you feel safe or do you feel comfortable in coming back to work? We gathered anonymous responses in the late summer. So here are some of those survey results. We asked, how has COVID-19 impacted your life? You can see that the vast majority have had a financial impact, and a very large number have contracted or live with somebody who contracted COVID-19, and over 20% have experienced a death of an important person in their life due to COVID-19. We asked who has high-risk conditions for COVID-19. About a third of respondents live with somebody who has a high-risk condition, and about 25% of people themselves have a high-risk condition for COVID-19. Really important. Now this is a question that we asked about, if you would accept in-person work, what would be the reasons for you to accept in-person work? You can see that 75% of people, it's a financial reason. you can see that over half of the respondents have a fear, and we're talking about now the power dynamic, that they might not be asked back for future work if they decline. So despite the fact that they would be verbally reassured, it's okay for you to decline, they still experience this fear, they still experience this pressure that they still need to say yes in order to continue getting work. And kind of as a control, we asked, the COVID threat is pretty much over. 2 out of nearly 130 people responded that they thought the COVID threat was really pretty much over. We also wanted to understand something about in-person power dynamics. So we asked if there were a faculty member, if there were a learner in your area who was within 6 feet or not wearing a mask or otherwise violating a safety protocol, would you feel comfortable in stopping the educational event until the problem was corrected? Less than half of the people said that they felt empowered to do that if it was a faculty member. And about 75% of people said that they would feel comfortable to address a learner. That still means to me that 1 out of every 4 episodes that this would be happening, the person would not feel empowered to speak up. And finally, we asked about work location preference. For human-based simulation, the vast majority do say that they would prefer to work remotely as opposed to in person prior to a vaccine ability. We work in our institution here with technology-based simulation as well. And you could see actually that there was more of a preference to do in-person work. And that makes sense with all of the technical issues with mannequins and things that, and many of our tech-based simulation operations specialists are also working as first responders in the field. So that may be a reason for the difference. We also provided an area, free text area, where they could write anything they wanted. And I wanted to share with you just a few of the many responses that we got. They are talking about vulnerability. All the things that we predicted: having an underlying condition, not having insurance, living with people who have had COVID-19 or have had COVID-19 themselves. They fairly strongly believe that working remotely is the way to go, even if they're accepting in-person work because there's no other option. And for those who have actually worked in person, this is really interesting. One of the observations that we heard about is it's not just about the safety issue. It's the cognitive bandwidth of needing to pay attention to, what am I touching? What is a learner touching? Are they over here? What's going on? Made it harder for this person to focus on doing the things that they usually do, which is focus on communication and checklist skills. And finally, this perhaps was the hardest hitting quote that one of our SPs provided. Feels like some of us are more expendable than others, and I think we've just accepted it. It's not a matter of if, just when. So having explored this with our SPs, we really learned that our SPs are extremely vulnerable. The idea that we're all adults and they can make this choice if they want. I think as employers and as leaders, we have a higher level of responsibility to be accountable for safety, especially understanding that these are the kinds of feelings that our SPs are feeling out there. So to conclude with this slide, looking at, in particular, the pelvic exam and the GTA MUDA exams, in no way can we achieve 6 feet of social distancing for this. And yet, this is happening. There are centers that have decided who are going forward with this. And part of our interest today is to open up a discussion around whether there are better answers out there and how really can we be responsible for our vulnerable workers. In terms of the takeaways here, the impacts have been very significant. People would choose remote versus in-person work, and we do continue to support that. And the factors accepting in-person work are all about vulnerability. and comfort with speaking up against a power gradient is really moderate at best. Now I'm going to conclude with this, which is a quote from 2015, so this was 5 years ago, talking about, in medicine, being stewards of a profession that requires us to do no harm, but beyond that, to help everyone live healthy and productive lives. And Dr. Martin Luther King's quote here really do resonate. We are caught in an inescapable network of mutuality, tied in a single garment of destiny. Whatever affects one directly affects all indirectly. And this means not just patients. This means the people who work with us and for us. So with that, that concludes our presentation, but we would like to open this up for a discussion now. And I'm gonna open the chats.
So while you're opening the chat, Christine,
Yes.
I would like to note that this is when we talk about structural violence or structural, like these are some of the elements that should be considered. The environment here is the structure, it's coercive. People need money, they need an opportunity to work. So we really, what I'm interested in talking about here is how do we have the conversations about how to safely provide work? What are the factors we take into consideration? What are the guiding principles? I so appreciate the study that you did because it went beyond just, I would return to work. I mean, those are questions I don't think I would have thought to ask of my standardized patients. But I appreciate that I could, you know, now because we're such a sharing community, turn to you when we're ready to go back and start to, you know, use your survey questions to get a sense of my own SP pool.
So I have an opening question to ask for the group, and we can allow you, if please, we want to hear from actual voices as well. So please feel free to text in, or we can unmute you as well. One of the questions that we have just to kick things off is to ask, where is the balance between our obligations to med ed versus our obligations to safety for our workers? And actually, I'm going to go ahead and stop the recording now.